Hi there. Welcome, and thank you for joining us for this first session of the series of the Infoway Partnership. I'm Mark Henick. For more than 20 years now, I've been involved in the mental health care system as a professional, as an advocate, and most importantly, as a patient. I'd like to take this initial moment because of that background to say how important that this event and events like this are to people like me. While yes, I've had the great opportunity to work in the mental health space now for a very long time, it's always been grounded in that personal experience. And as we say in the mental health space, we can have nothing about us without us. So without further ado, I'd like to start by acknowledging the territories on which we're hosting this meeting and the lands on which you're joining and calling in today. Canada Health Infoway recognizes that the many injustices experienced by the Indigenous people of what we now call Canada continues to affect their health and well-being. Canada Health Infoway respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees today to reflect on the territories that you're calling in from as we commit ourselves to gaining new knowledge, forging new culturally safe relationships, and contributing to reconciliation. Now, I have a few notes that I'd like to cover before we get started with my own personal remarks. First and foremost, of course, translation services. We have simultaneous translation available in French. And if you've not already found the connection details, you can take a look at the slide in front of you there now. And we're going to be sharing it on the screens. I'll give you a moment to take a look at that. Now, Infoway is very proud to continue to convene events which adhere to the Patients Included initiative. The Infoway Partnership Fall Series Patient Advisor is Anne O'Riordan. Anne has been involved in the summer, contributing to the planning and the program that will continue to work with us on the series moving forward. So Anne, thank you so much. It's so important to have people like us, and it turns out there are many, many of us out there, people who have lived experience of the healthcare system, actively advising on initiatives of this nature. So Anne, thank you. The Infoway Partnership Fall Series has been made possible due to a partnership, many partnerships, in fact, within the industry. On behalf of Canada Health Infoway, thank you to the Access 2022 Alliance founding sponsors, and you see them on your screen there now. Infoway is taking part in a community engagement project in support of Native Canadian Centre of Toronto. Attendees are welcome to donate via their online portal. The NCCT is a charitable organization that empowers the Indigenous community in Toronto by providing programs that support their spiritual, emotional, physical, and mental well-being. And we know in the mental health space that it's so much more than just all in your head. We can learn so many lessons from Indigenous communities in this respect, and this is just such a great organization that helps to show us the way. We're going to be looking for your thoughts today throughout the event, so watch for the polls and the navigation slide to your right. Our chat moderator will let you know when that's live as well. So we're going to try our best to be able to take as many of your questions and to run these polls too. We're going to try our best to stay on time, of course. It's always a little bit difficult in events like this, but we're going to be quite strict with it this time to honor your time as well. And we've planned to allow for these questions at the conclusion of each presentation. So submit your questions in the via the Q&A box on the right, and you can also upvote the questions that you want to move to the top. Doing these kinds of events, usually many of you have very similar reactions or similar questions, so let's vote those up, and we can address as many of them as we can. Now, let's get over to me, a little bit more about me. Who's this guy who's sitting in front of us today, and why should I be here talking to you about health and mental health in particular? Well, as I mentioned, my name is Mark Henick. You see me there, up there on the screen. You can follow me at all of the social media outlets, Twitter, Facebook, Instagram, and everywhere else at Mark Henick. And for my entire professional career, I've been talking about mental health, mental illness, and especially recovery. These issues are so important to me because I mentioned right at the top that for more than 20 years now, it's all that I've been doing, both clinically, professionally, academically, and personally. It all started with me in many respects, I think, the night that I was pulled off of the edge of a bridge by a complete stranger. I was 15 years old at the time, standing on the edge of a bridge in Sydney, Nova Scotia. Cape Breton used to be a mining town, a steel city, one of the largest steel manufacturing hubs on the entire eastern seaboard. But by the time I was growing up, the steel industry had largely shut down. The plant was still standing, but just barely. Many people, almost everybody it seemed that I knew, had lost their jobs. My entire family, in fact, who were so deeply connected to that space. I don't know if you know much about the East Coast or how many people are joining us from the East Coast today, but I have 32 plus, as far as I know, aunts and uncles. My grandmother on my mother's side had 16. My grandmother on my father's side had 15 that we know of, and there are many more. The reason why I say that's an East Coast thing, because it seems to be a very Irish Catholic thing too. But the reason why I mention it in these presentations is that we were a tight-knit community, and in a small town where you're seemingly related to half the people in the town anyway, everybody knows your business. A lot of people know what you've gone through, for better or worse. Everybody seems to know who's been drinking too much, or who crashed their truck into the ditch, who's lost their house or their job or their kid. But it seemed like when I was growing up as a young person, everybody knew about the mental health struggles that I'd been having since I was at least 8 years old. And everybody would talk to each other about them, but they wouldn't talk to me. It wasn't necessarily forbidden, but it just wasn't normal to talk about our emotions in a place where, as we all knew, everybody had it hard. Life is hard in Cape Breton. What makes you special? I heard that so many times. The result, however, for me was that I was feeling all these feelings and I didn't know what they were. And many of them perhaps very normal, but many of them very much informed by the trauma and the bullying that I was experiencing as a young person. That feeling of being trapped in an environment where it wasn't healthy for me, but there was nobody to help, let alone to ask for help. We didn't have digital health services at the time. We didn't have any ability to connect not only with doctors and mental health care providers at the time, but we didn't have the ability to connect with each other digitally at that time. So it was an incredibly isolating place to be, not only in my community, in my small town, in my stepfather's house that I moved to in the second grade out in the middle of the woods with 100 acres of forest on every side and outside of my basement bedroom, but it was very isolating inside my head too. I think in many ways it was a coping mechanism that I turned into myself, that I turned away from others, that I didn't want to connect with anybody around me, even if they did reach out. Sometimes, especially if they did reach out, it caused me to retreat even more. But of course, we know that the more you don't allow your mind to express itself in the world, the more you cut off connections with the outside world into your own mind, the more concentrated, the more toxic sometimes the thoughts in your own head can become. And that's exactly what had been happening to me from the ages of about 8 until 15. I had a number of suicide attempts, and these suicide attempts really were the culmination of so many other struggles that I was experiencing with anxiety, with depression. I was in and out of hospital more than a half a dozen times for these increasingly dangerous suicide attempts. Attempts, I think, that were efforts at finding help, at cries for help, for somebody, anybody, to connect with me and understand me. What brought me to the bridge that night, when I had climbed over the railing at about midnight on a Sunday night in March, was this idea that I was helpless, that I was hopeless, that nothing that I would ever do, that none of these very smart people who had been trying to help me over the years ever could. It felt like while everybody was surprised when I first went into hospital, I later pulled the medical records from all of these hospitalizations for my upcoming book. And the note under that very first admission in April, just before my 13th birthday, included a quote from my mother in which she told the nurse, "We didn't see this coming." I thought that was such a shock because I had felt it coming for so long, that first suicide attempt, that first hospital visit. So while everybody was shocked by the first time, by the end, I had become a frequent flyer, as they're known in the healthcare system, unaffectionately, of course. I felt like I had become one of those people who the more help they need, the less help they get. So I had climbed up over that railing intending to kill myself because I felt like there were no other options. And it didn't matter that there were. It didn't matter that there was a whole world of other options outside of my head and outside of my little small town, outside of my closed circles, because I couldn't see them. And if you can't see the options, then they're not available. They're not accessible for you. I sat in those thoughts overlooking the old abandoned steel plant on that bridge for I don't know how long. It wasn't until I was interrupted, though, that I started to get a better sense of the time that was happening and passing by me. It was a man's voice over my shoulder, and he said, "You don't look like you're doing so good." I wasn't doing very well as I stood on the edge of that bridge, ready to end my life, thinking that there was no help, no hope ever available for somebody like me, that I was broken, and that I would be doing people a favor if I ended my life. But when that stranger came up behind me, I couldn't see him the way that I was perched on the edge of the bridge, and it was dark as well in the middle of the night. I could only see out of the corner of my eye that he was wearing a light brown jacket. I'm sure he introduced himself to me, but I had very little contact with reality at that point, so I either didn't hear or didn't remember. But we talked for a little while, and what stood out to me the most, while we didn't say much, and I said even less than he did, was the types of questions that he asked me. I could tell very early on that he wasn't a healthcare provider. I had felt like I had memorized all the questions they had asked me over the years. I had talked to dozens of psychiatrists and psychologists, nurses, social workers, teachers, priests, everybody who was trying to help me, to fix me, as though I was a broken down car on the side of the road. I could tell that this stranger wasn't a healthcare provider, though, because he didn't ask me any of those questions. He didn't run down the Beck depression inventory with me. He didn't ask me which medications I was on. I had been on a lot. I felt like all of them. He didn't ask me which therapies I had tried or anything about the approaches that we had tried in hospital. Instead, I think he asked me about my cat. He asked me if I had any hobbies, who my friends were, what my parents were like, what I liked to do at home. He asked me about my passions and my interests, what I was good at school. I didn't feel like I was good at much, but we found at least one thing to talk about, even if there were 10 others that I felt I wasn't good at. As we spent that time talking to one another, connecting, I could almost feel the rigidity of my mind dissolving a little bit more. I had locked myself in this, I had collapsed into this perception that my life would never get any better. And it was only through building the connection with this complete stranger who I had no idea who he even was. He had never met me before either, that started to dissolve, and I started to see the world around me a little bit more realistically. When it finally did, I looked to my sides and I realized that the police had arrived. I didn't hear them there at the time because I was so dissociated. I didn't realize that they had arrived. They had set up sawhorse wooden yellow barricades on either side of the bridge, and when I looked to either side, I could see the crowds had gathered. There's not much to do in small towns, so a lot of people listen to the police scanner to see if there's any action happening. The crowds were on the sidelines, and I remember feeling this stranger behind me who I'd connected with, but then suddenly my focus turned to these people that I could barely hear, could barely see, who had gathered on the sidelines, and who weren't trying to connect with me, who were just watching it happen, maybe hoping for a spectacle. I could swear, and I don't know if it was just the noise in my head or if it was noise from the sidelines, but one of them shouted out to me. He said, "Jump, you coward." In that moment, the dissolution of that collapse of my perceptual boundaries that had kept me locked in that place, it all came flooding back in again. That's all that it took, was that somebody to stand on the sidelines and disconnect from me, to push me away. It didn't matter that I had this stranger because the balance of power in that moment shifted back toward disconnection and not wanting to see me thrive and succeed. So when he told me to jump, I let go of the railing. And as soon as I did, I was practically nothing under my feet. Only my heels were on the concrete, and it was could have been a 30-foot drop. It could have been a 50-foot drop. I don't know. Everything seems a lot bigger when you're small, especially when you feel small. I let go of the railing and I started to fall, and I remember seeing the ground come toward my face, and I remember feeling a sense of relief, that I didn't know how to solve my problems, but this seemed like a final solution. And then I saw the light brown jacket of the stranger who'd been standing behind me. I saw his arm come out from behind, wrap around my chest like it was in slow motion. He pulled me backward, and when he did, my back hit the railing that was behind me. My feet flew up off of the bridge, and I dangled there. In the police report that I later looked through for my upcoming book in January, they had said that I had gone completely limp, like I had given up. He held me there for a moment, that stranger, and then he pulled me back over the railing. I felt another hand grab the back of my jacket. It later turned out there was another police officer there too. They loaded me into the ambulance and I was shipped off to hospital again, back to the basement psych ward at the Cape Breton Regional Hospital, just like all the psych wards in the movies. Cinder block, gray, not many windows, scary. I had been there before. It was the place where everybody had known my name. I stayed for a couple of days and I was discharged without getting any real help from the formal system as it exists. But something did change for me that night after that admission to hospital that didn't change all those other times. When you have a mental health problem or illness that affects your focus, your attention, and that is the things which you focus on and attend to, the things on which you lock in, for some reason, that pathological focus, that pathological attention locked in on this image of this man who had been standing behind me, this complete stranger. It locked in on the comparison or the contrast between him and the one who chose to stand on the sidelines. How different they were, these two people observing the exact same situation unfold before them. How different the choices each of them made. One decided to shout out, to push me over. The other decided to reach out and to save my life. I realized when I spun through the revolving door of the hospital upon that admission that maybe I had more choice in my life than I thought that I ever had. Maybe I actually got to choose in some rudimentary way which of those two men I could be like, which of those two strangers I wanted to grow up to be. The one who pushed people away or the one who reached out and connected. When I decided that I wanted to be more like the man who saved my life, I'll be honest with you, it's not like everything, hallelujah, changed in a moment, turned on a dime. It wasn't a sudden redemption story. Recovery takes work. And if you don't do the work, you backslide a lot. It turns out even if you do the work, you backslide a lot, and that's part of the process. I didn't know that at the time when I was going through it, that recovery involves relapse, that you're learning, not failing. But over the years, I clung to that image of that stranger on that bridge who reached out and connected with me and saved my life. I was discharged from hospital for the very last time on the first day of spring. Ever since then, for the 10 years after, I spent my life wondering who that man was. It was a few years ago that I had finally built up a speaking career. I had been writing more frequently. I'd been working clinically, had gone to school to study these issues and myself. And I finally decided it was time to reach out and find that man. I had developed a relationship at that time with Canada AM, which was then Canada's longest running and most watched morning news program. I went on the air the day after Bell Let's Talk Day because I'm a big supporter of Bell Let's Talk Day, but I'm also a big supporter of talking every day about mental health and well-being. I asked for the public's help in finding this stranger who saved my life. Within an hour, we were able to locate him. It turns out he had seen a TED Talk that I had done a few years earlier in which I talk about him, in which I share that story that I just shared you. He had seen the TED Talk, and he didn't know up until that point that I was still alive. He had seen the TED Talk, in fact, and he had already written me a letter in case someday he ever found me. Lo and behold, I start to look for him too. They reached out to me, somebody who knew him, his roommate at the time, in fact. They asked if they could send me the letter. I agreed, and they did, and it arrived in my email inbox and sat there for about 12 hours because suddenly I was terrified that my entire identity was going to change. My entire story was going to change, and I wasn't sure I was ready for that. But when I finally was, around midnight on a Sunday night, I turned on my camera on my iPad because that's what normal people do, right? At really vulnerable times in their life, they record themselves for the whole world to see. So if you ever want to see a video of a guy really ugly crying on the camera, you can look up that video on YouTube. It's still there. I read this letter from the stranger in the light brown jacket who saved my life. His very first words were, "Hi, Mark. My name is Mike." Suddenly the stranger had a name. And if he had a name, it meant that he was real. He told me all about everything that he saw that night. It was like watching my own story from a different camera angle. He told me that when he saw my TED Talk, he never knew how proud he could be of somebody he had spent so little time with. We invited Mike up to Toronto, where I was living at the time, still am living now. We had a reunion in which the moment he saw me, he didn't say a word. He just wrapped his arms around me, and he gave me the biggest hug that I've ever had. He reconnected with me again after all those years, and he felt safe. Ladies and gentlemen, I want you to know today that the work that you do, whatever way you work with people, building that connection, forming that connection, whether it's in person or now in this new normal, can indeed save lives. I want to thank you so much again for joining me today. It brings us right on time, literally right down to the second. How about that? For a chance to have a little bit of a conversation. I'm not going to have a chance to answer questions right now, but we are committed to answering some questions in the post-event follow-up communications. So we're going to document those questions that are submitted. I want you to submit some questions for me about my own personal lived experience. I am literally open about everything. So if you have any concerns, I might not be able to help you clinically. Actually, in fact, I certainly can't, but I'm willing to help you connect with resources and services that might be helpful for you. So I'm going to leave you a quick poll to think about here. Understanding the impacts of COVID-19 on Canadians, the current state of public health data, and future plans. We're going to move on to, oh, hold on one second here. I think I missed a poll question. Can we get our producer just to give me a little bit of guidance on that point? Alrighty, thank you. So let's get into our next presentation. It's now my pleasure to introduce Rhonda Kropp, the Associate Vice President of Infectious Disease Prevention and Control Branch for the Public Health Agency of Canada. Rhonda, over to you.
Thank you so much, Mark. And I have to say, I know we have no time for this, but I'm doing it anyways. I'm really touched and honored to have heard your story today. Thank you for that. I really do appreciate it. I am going to spend a little bit of time today to talk about the experience of public health data and what we have learned over the course of COVID, as well as our future plans to address some of the short-term and long-term issues that we are finding with COVID data over the course of this pandemic. And I want to start first by thanking the Infoway Partnership for the opportunity to have this conversation. There's a lot of lessons learned and a lot of people that are working in data. It's a very broad term. And this is one snippet of the work that's being done. And I'm honored to be able to share with you today our experience and thoughts on that front. So today I'm going to provide an overview of the current surveillance program that we're using for COVID, which may be broader than some people would expect. I'm also going to summarize the current state of our health system data in regards to COVID, but also some of the concerns that are coming to light in relation to long-term systemic issues that are impacting our collective ability to use the data we have in Canada to the best of our ability. So I'll start first by giving you a quick overview of the surveillance program that we have. So as one can imagine, in the public health world, when we started to see the reports of COVID cases happening internationally, we very quickly launched into an opportunity to speak with our provincial and territorial colleagues to set up a new surveillance system. It's not the first time that we have done that. We've done that in past pandemics. So there is very well-established governance that we can bring to bear when these situations arise, which was what we did in this case. Our focus at the beginning of the pandemic, as one can understand, would be to understand, describe, and monitor the transmission and distribution. So some of the more in-depth knowledge that we are now seeking, that was of course important, but at the very beginning of the pandemic, you want to be able to identify how many cases do we have, where are they, what is their severity, and is the health system able to handle this? So that's where the focus was. But our surveillance goes far beyond the COVID case data that is reported every day in multiple venues. So certainly we have the information that we release, that we get from the provinces and territory on cases. We also have information we get from testing. But there's a whole slew of other surveillance systems that are brought to bear in situations of this nature, recognizing that our case surveillance is never on its own going to be able to answer all of the questions that we want to be able to answer. So we've got syndromic surveillance data that we're collecting through the COVID Thrive app and through Flu Watch, for example. We're doing web scraping of data. The reason for that being that sometimes the data and information that is being posted on provincial and territorial sites comes faster than it may come to us. So we get some of the web scraping data that way. We're also looking at mobility. So we needed to understand over the course of the pandemic whether public health interventions that were being recommended were actually being put in place. And we can say that Canadians took incredible effort to reduce their mobility when that was asked of them. It's really an unbelievable testament to the public health nature of our country. So we have all of these existing data sources, but even with those, a number of gaps and evolving data needs are understandable and to be expected. So as the pandemic evolves, we have different data needs that we need to consider and create the space to collect those. So for example, while we were focused at the beginning on case counts and case numbers, those are still very important, but now we also need to understand where the outbreaks are occurring. What are the nature of those outbreaks? Now that we understand a little bit more about the dynamics of the infection itself. So over time, the community that is working on the COVID surveillance is checking two things. Are we collecting the right information at each stage? And also assessing the information that we do collect. Does it have the appropriate completeness and granularity for us to be able to use the data in the way that we want to be able to use it? And some issues that are in the public health data landscape and have been for quite some time that continue to emerge over the COVID landscape is ensuring that data is shared in a timely fashion and analyzed in a timely fashion so that it can be used very quickly for public health decision making. The completeness of the data, obviously incomplete data impacts the quality. Granularity, very important, that if we have specific variables that allow us to dig a little bit deeper on particular subpopulations that may be at risk. Access to data, ensuring that we are providing access to the COVID data set and other information so that decision makers across the country and researchers are able to access and use that information to add to the knowledge base. Standardization of data is a very important piece. I'll be talking a little bit more about that in a minute. And also ensuring that the data sets that we have a identifier that is consistent with privacy legislation, but also allows us to link data sets so we can get the best information we can out of the data that we currently have in Canada. So to summarize, the problem we're trying to solve in the longer term is really to address some of those long-standing systemic issues that are resulting in some of those pieces I just mentioned. Governance is one. Canada has a broad health governance infrastructure currently, but we don't necessarily have an integrated governance structure for public health data, population health data, health system data, that would allow us as a data community to, on a regular basis, speak to one another, talk about what the priorities are, and then decide who's going to do what so we're most efficiently using our collective resources. As I mentioned, standards very, very important. We've got a number of different parties across Canada who work on different standards and different standards then being applied, which then makes us question if we have standards and how do we actually optimize that so that we can have the numerous data providers and sources, the data sets resulting from those, have the ability to extract the maximum amount of intelligence that we can. We also have diverse data systems across the country. Healthcare partners have understandably invested in solutions that are appropriate for their situation. And so we need to have the ability to pull the intelligence out of these diverse systems so that we don't lose the intelligence that is embedded within them. And finally, we know that there are HR capacity issues when it comes to our data and analytical support. As I'm sure will be mentioned with speakers later, the landscape for data and technology in Canada has evolved so quickly, and we need to ensure that as a health and public health community that we're keeping pace with that technology so we can bring it to bear for the betterment of our stakeholders. So building on our successes, I wanted to talk a bit about what are we doing then to address all of those issues. In the context of COVID, Canada has created a testing strategy, and it has three pillars. One is testing, one is contact tracing, and one is data management. Under the data management pillar, we have an action plan that has very distinct priorities for the gaps that I have currently mentioned, both for the short term as well as for the long term. And I really want to flag that the development of that plan was a partnership between the Public Health Agency of Canada, our partners at Health Canada, Statistics Canada, Indigenous Services Canada, CIHR, as well as in consultation with our partners in the Canadian Institute for Health Information. We're challenged with getting a plan together very, very quickly and doing so within the federal family. And we were able to create a plan that addresses both the short and long term in a collaborative fashion, which will ultimately allow us to, in a better and more collaborative way, address those issues together using the expertise and the levers that all the different departments have. The next slide focuses on each of the priorities, and as you can see, if I spoke to all of these, I would well exceed my time, so I will not. But I did want to focus on a few of the key priorities that I think will likely be of interest to the audience that may be attending this today. Specifically, I wanted to talk about our case data content, which is critical. Also wanted to talk about data access, as well as race, ethnicity, Indigenous, and healthcare populations who are at particular risk, and we need really good data on those populations to support them. Also, I wanted to speak about our long-term health data strategy a bit, because that really does hit the key long-term systemic issues that are impacting our data community. So I'll start with the first, which is improving case data. And as I mentioned, we very quickly stood up a surveillance system that included the reporting of case data from provinces and territories to the Public Health Agency of Canada. And I'm really happy to say that partnership has been very successful in that we get just under 100%, over 99% of the cases in Canada have a report that comes to FAC, which is incredible. Also, for each of those cases, the demographic variables are completed at above 98%. So we're getting very, very good data. Where we have a different level of completeness, it really depends on the jurisdiction and on the variables of mention, including hospitalization, ICU, and death, for example. For some jurisdictions where the source of that information is linked very closely with the public health information, that information is quite easy to roll in. For other jurisdictions where that information may be sitting separately within the health system and not within public health, those connections may not be made as easily or as quickly. There's also gaps that exist for some of our subpopulations, and I wanted to flag these in particular because we're making a lot of effort to try to address these concerns. The first is Indigenous communities. We've been collecting information on Indigenous status in our data set since the very beginning of the pandemic, but that information is currently quite poorly completed. And that is, again, the result of a number of different things. It is not a willingness to report from the provinces and territories. They've been reporting incredibly well, but there are differences in mandates for Indigenous data across jurisdictions that have hindered our ability to get that information. Healthcare workers is another community that, of course, we want to get really good information on. And while we've been collecting information on that throughout the pandemic, the information we've collected does not have sufficient granularity in order for us to really pick apart what is actually happening for this community. What are the venues in which the infections are happening? Is it linked to work? Is it community-based? What type of healthcare workers are at particular risk? We don't have that granularity in our current case data set to be able to answer those questions. And finally, racialized and ethnic communities, a lot of interest for very good reason in understanding the impact and burden of COVID-19 amongst those groups, and our initial data set did not collect race. So we have a number of pieces going forward to rectify these issues. Indeed, we've got a new national data set that was approved in July and is now being operationalized this month. And I'm going to spend a little bit of time on this itsy bitsy slide that I am going to talk through the key pieces for you. This new national data set that is going to start to be reported in part this month really provides some very specific improvements on the way we are collecting data. And again, this reflects the change that we're in the current state of the pandemic, that we now understand the case numbers, we understand the capacity of our health system to deal with COVID-19, we understand the general demographics, we're now in a space where we can do far more of a deep dive to understand other factors of interest, as I've mentioned. In the third column under case details, we've got additional variables now on occupational type. This allows us to drill down on the healthcare worker sector in particular, where we're asking questions about venue, type of healthcare worker, etc., as I've mentioned. We also have population group specifics, which is where race, ethnicity, and indigeneity will also be captured. So this really makes us one very large step forward in being able to understand the impact of the infection on different communities. On the far right, under exposures, we also have a large increase in the amount of information we're collecting in the red. So we are getting information not just on whether a case is linked to international travel, but now we're getting information on, is it linked to international travel, domestic travel, an outbreak, a known cluster. This will allow us to be able to detect what proportion of the cases that we're seeing in Canada in the next series of time for the pandemic is linked to an outbreak versus something that is community-based or unlinked and we don't know where it came from. So that's really going to allow us to very quickly pinpoint where cases are occurring and to be able to work with the PTs to act to reduce those outbreaks. On the next slide, once we have our case data, that case data is only going to take us so far. There are some questions that are very specific for key populations where we need to use different methodology to drill deeper to answer some of the key questions. So we've, in addition to the case data, one of the priorities, as you noted within our data management pillar, is to provide other sources of information to round out our intelligence for racialized and ethnic minority groups, for healthcare workers, and for Indigenous communities as well. For race and ethnicity, we've done a number of things already. We haven't listed everything here, but just some examples. So we have a summary of existing data that was already done, recognizing that there is quite a bit of information in the literature that's already been published, and we wanted to summarize that information to make that easily understood and easily uptaken by people to act. So that was released. We're also currently in the process of developing with CIHI new standards on data collection for race and ethnicity, as well as partnering with Statistics Canada on a number of surveys that will allow us to have some new data on a racialized community, and that work is launching in very short order. And finally, we're in discussions with community groups themselves to try to look at whether there's an opportunity to support communities in gathering and using data with and by their communities. So we're starting with the African Caribbean Black community in Ottawa, who's expressed quite a bit of interest. And we're looking at doing a pilot that we would like to learn from and then apply this to other communities across Canada going forward. In addition to these pieces for racialized communities, for Indigenous communities, we have a number of new data collection projects that we're supporting. We're doing that work in partnership with our partners at Indigenous Services Canada, with an eye towards providing direct support to national Indigenous organizations so they can undertake Indigenous-led data collection and analysis. That work is well underway. And for healthcare workers, we have two releases that are happening in the coming weeks. There's one by our partners at CIHI and one based on our national data set as well. And we're also working with a number of different healthcare worker communities, including nursing unions, as well as the Chief Public Health Officers Health Professionals Forum, to work with them to understand what are the key questions that really do need to be answered for these communities, and then to develop a research plan to address those questions that have been identified as of critical importance by the health community themselves. So that plan has been developed and it is currently in the process of being implemented. We're also looking at unintended consequences, and this was raised earlier on as well. We recognize that unintended consequences of the infection, as well as the public health measures that have been put in place to control it, are something we really need to understand. Mental health, family violence in particular, are of great concern to a number of communities with very good reason. Also, food insecurity, substance use and overdose patterns, as well as patterns of self-harm and suicide We want to understand the impacts of the infection and also of the public health measures put in place. And so data collection and analysis in these particular areas are happening with a focus on underrepresented and excluded populations, as well as looking at SGBA plus analysis to see what the sex gender-based influences may be on these particular experiences throughout the pandemic. This work is very well underway, and I have to say I had an update on it this morning, which was very, very impressive. So we can expect that some of this information is going to be released in very short order. And again, this is a partnership between FACTS, Statistics Canada, and Health Canada, who all have a role to play in different levers that we have to gather and use this information. In addition to these short-term measures that are focused on improving our COVID-19 understanding, the longer-term systemic issues that I mentioned are also of critical importance. So we are in the process of developing, and in early days, of developing a health data strategy for Canada. For those of us that have worked in the data community for a long time, this may sound like Groundhog Day. What I will note to you is that there is a recognition that we need to learn from our attempts to do this type of work in the past to ensure that we take the best from those attempts and also learn why things didn't work. The intent here is not just to look at public health. To be clear, it's to look at the health data writ large, health system data, population health data, as well as social determinants data and public health data. So we are working with Dr. Vivek Goul, who many of you will know as our data champion. He will be assisting us in the bringing together of an expert advisory group that will consult on this work. We will also have a very large and broad consultation plan that will go along with this work. We recognize that there are a lot of people who are impacted and interested in this type of work going forward. We're going to make all efforts we can to ensure we are getting meaningful input from those partners as well. We're just in the process of landing our first draft of the scope, as well as of the EAG, and also of our consultation plan for review by deputy ministers, after which we're going to start going out and talking to folks. So people can expect that we'll be out consulting on this within the month or so. So we're very, very excited about this work and very excited to see how we can improve the use of the data we already have in Canada for the betterment of the health of all Canadians. I'll just summarize by saying that as the pandemic evolves, we are going to continue to look at our surveillance systems to ensure that we are collecting what we need to collect. Having intelligence on subpopulations is always a challenge, and we recognize that we will get some of that through our case data, but that we need to do those additional studies and work that I mentioned to really get to the heart of the experiences of those communities and to work directly with those communities to understand what their information needs are and work hand in hand to get it. We're also ensuring that we're doing the best we can to get disaggregated data on the national COVID cases, and we will be creating a national COVID data portal where we will be putting that information. The COVID data set is currently available through Statistics Canada. Public Health Agency of Canada gives StatsCan that information weekly to post so that people can access it. But the COVID portal will go one step further to provide support for development of reports and controlled access to that data so that individuals who need to use it can have access to it. And altogether, the suite of activities that I've mentioned, both for the short and long term, really are aiming to increase our ability to monitor the impact and the burden of COVID-19, but also to address those systemic issues that have been impacting our data community in the health realm for quite some time. So I think I will stop there. I've tried to leave some minutes for questions. If people have questions, I'd be delighted to answer them. And again, I just want to thank the Infoway series for the opportunity to provide this overview on what we've done to date and what we're planning on doing. As you can imagine, it's been a very challenging number of months, and we've got a lot of incredible public health, and population health experts who are bringing their expertise to bear on these projects, and a huge thank you to their collaboration as well.
Thank you so much, Rhonda. You know, hearing you talk about the unintended consequences of the COVID-19 pandemic, of course, naturally, that was going to grab my attention. We've been concerned about a coming echo pandemic of mental health problems and illnesses. And indeed, I think we're probably already in that wave of the pandemic. So it's heartening to hear, for someone like me anyway, who relies on data and facts to feel comfort, that you're very actively tracking these measurables as well. I think that will be very helpful. So we have time for one or two questions from the audience. As I mentioned before, we're going to respond to some more in the follow-up communications. So one that I have here for you, Rhonda, is if you're capturing sex and gender data.
Yeah, so that's a really important point. So SGBA, and not just SGBA, but SGBA Plus, is a really, really critical lens through which we do all of our work. There are always challenges with race data and for using a single standard. So the work that we're doing in that area, I'm very happy to say for our case data, we've developed a single standard that will be used by the provinces and territories as they report it. That's really, really going to help us to be able to take a look at what is happening for racialized communities. SGBA is a really important lens, and of course the Public Health Agency has a champion for SGBA, so our work is also being touched very closely by that champion, not just for COVID, but also for the long-term health data strategy. One of the challenges that we've had in the health realm with data has certainly been the ability to disaggregate and provide information for different groups of individuals within Canada, recognizing that we can't just roll everything up. For example, to male and female, we've got a diversity of expressions in Canada that we need to respect and understand the impacts on them. So we're really actively working in that area, and that is going to be one of the critical discussions for the health data strategy. In public health, we do this fairly well, but when we're thinking about research studies, we're thinking about health system data, and public health, what can we do to really raise the bar? We've made some progress, but if we were really going to do this right, is there a set of guidance, a set of approaches that we're able to put forward to support the many people working in data to collect this information in the best possible way for us to disaggregate and provide information for subpopulations? That will be a critical discussion for the long-term health data strategy, and is certainly informing the way we do our work for the COVID data in and of itself now as well. So I really thank you for that question. It's a personal piece for me as well. I have a particular interest in that component. So we're keeping a very, very close eye.
Yeah, it's interesting to hear you mention the wide spectrum, of course, of gender expression, because gender minority communities are very vulnerable, especially to mental health problems and illnesses, but a variety of healthcare issues. So another question that we got touches on that. How closely does the Public Health Agency of Canada collaborate with health systems to coordinate planning for those most in need, according to the data that you're seeing?
Yeah, that's a really, really good question. And my answer is not going to be as good as your question, I'll be honest. What I would say is we continue in Canada to have a bit of an unnatural silo between public health data and health system data, and population health data as well, I would say. And that has really created an issue with our ability to bring all of the various pieces of information, not just the data, but the intelligence from those pieces of information together. One of the reasons why the health data strategy is not focused just on health system or population health or public health is for the exact reason that the person who gave the question, which is we're really not doing that as well as we could. So in the federal government, we have really close links between Public Health, Statistics Canada, Hi, and Health Canada, and our research colleagues as well. However, we are all in different organizations, and that naturally creates this organizational silo that, if we're not careful, can also create data and intelligence silos. So one of the key reasons for trying to do a health data strategy that is broader is to ensure that we are thinking about these pieces not in isolation, but what the intelligence across all of them can bring to bear when we use them to the best of our ability as a health data community, not just public health or health system. So overall, my summary of my answer would be, we don't do it as well as we could. We certainly make all efforts we can to ensure that we're trying to get our public health and health system data together, but we also know that there's some organizational and also infrastructure barriers that hinder our ability to do that. And that will, again, be one of the key pieces we talk about with our health data strategy going forward, because we do recognize we need to improve in that area.
Now, on that data front, is the COVID data set mentioned being available through StatsCan the new national data set or a subset of this data?
Yeah, good point. So we are currently, what we provide to StatsCan to post is whatever we have. So whenever we have it, we make it available. So as soon as the new national data set, which has those additional variables being reported, as soon as those are reported, those will also be made available. And ultimately, once we have our data portal in place, that will be even easier to allow, for example, regional public health, health system partners, our provinces and territories to have controlled access. Again, recognizing privacy, incredibly, incredibly important. That data has to be treated to ensure it is a private data set without any ability for re-identification, of course. That will really help folks to be able to get really easy access and manipulate and use that data to do good for public health in the time of COVID. So whenever we have the data, that is what we're making available. So as soon as the new variables start to be reported, they will also be in that data set that's made available.
That's great. I think I have time to squeeze in one more here. How can the ACB graduate students get involved in the ACB Ottawa pilot study?
Oh, that's awesome. I love that. So we are currently creating that pilot with some partners. My suggestion would be to email me. How do we provide my email address without me getting a whole bunch of emails from people on a number of things? But honestly, I would say to email me directly. It's rhonda.kropp2@canada.ca. I would be more than happy to link interested people up with the leads for that work. And it's still early days, so lots of time to get involved, and we would be delighted to have people who are interested get involved.
Rhonda Kropp is the Associate Vice President of Infectious Disease Prevention and Control Branch, Public Health Agency of Canada. Rhonda, thank you so much for your presentation today.
Thank you so much for the opportunity.
All right, we're going to have another poll running for you to check out, and we're going to get started at 2 p.m. We're going to take a little break, so we'll put those poll questions up there. You can take a little stretch, go for a little walk, get a coffee, but make sure you get back here at 2 p.m. We're going to get started right away. Welcome back, everyone. I'm Mark Henick. It's my pleasure to introduce the next session, and it's especially my distinct pleasure to say that we're bringing in the big guns. We have Michael Green, the President and CEO of Canada Health Infoway. Michael, over to you.
Great. Well, thanks very much, Mark, and thanks to Rhonda, and also in anticipation, I'd like to thank Daniel for his talk, which is after mine. So first of all, welcome to first of 3 Infoway Partnership Fall Series. This is Infoway's first virtual conference series. Like a lot of organizations, we've moved our conference to a virtual platform, and we're bringing you the partnership event you expect in 3 chunks this time. So at first today, then the second's going to be in October, and the last event in the series will take place during Digital Health Week on November the 17th. We have an excellent program lined up for you, and I'm thrilled that you're all able to join us. Well, as we all know, the world has really changed, and wow, who would have thought that when we were sitting in Ottawa at the Partnership Conference last year, that the world would have changed so drastically. We're in the middle of a global pandemic, a virus which has infected over 28 million people across the world and killed nearly 1 million. It sounds like the plot of a bad sci-fi music or Brad Pitt in World Z or something like that, but this is reality. And the impact is real, and it is global, and no one will argue anymore that we live in a global community. What happens in Wuhan province in China affects lives in downtown Montreal or rural Manitoba. We've also become painfully aware that health is wealth. The economic impact of COVID has been profound and underscores the importance of keeping our populations healthy. Investing in health is investing in the economy. This pandemic has also taught us some very important lessons about the need to ensure that everyone has access to resources they need to be well and to stay safe. The social determinants of health and how we treat our most vulnerable populations will dictate how safe we are as a country and as a community going forward. Closer to home, those of us working in or experiencing the health system have seen the profound and sudden impact of the virus, including the almost overnight transition from in-person care to virtual care delivery. In March and April, about 6 in 10 healthcare encounters were done virtually. This is a significant jump from the pre-COVID environment. The spike in virtual care visits is just one example of how the system reacted very quickly to respond to the pandemic and to keep Canadians safe. And while this switch was quick, it required a lot of people working very hard to make it happen. In fact, one of the key themes that characterizes the early days of COVID-19 for me is the unprecedented collaboration. And let me give you just one example. Very early on in the pandemic, Infoway established a COVID Rapid Response Fund by reallocating internal resources. We reached out to our jurisdictional partners, meeting with them individually and collectively and very frequently. And together we identified 3 common priorities. First one was the augmentation of virtual teletriage / 811 services into a more digital kind of format. The second one was increasing the capacity to deliver virtual care, including remote patient monitoring. And then thirdly, ensuring that citizens could access their lab results, particular COVID results, rapidly. Within 45 days of the Rapid Response Fund being created, we'd approved 14 projects with at least one initiative in each of the provinces and territories. And each of these projects was rolled out within a month of them being approved. This really wouldn't have been possible without the unprecedented level of collaboration I spoke about earlier. It was an incredible accomplishment, and it's having an impact already. More than 1.15 million virtual care sessions or uses have been reported cumulatively across these projects since March 2020. And projects in BC, Alberta, Manitoba, Quebec, New Brunswick, Nova Scotia, and Newfoundland are well ahead of the adoption targets for e-visits and for e-results. We've also stepped up our work with Health Canada and our federal government partners. It won't surprise you to hear that virtual care is front and center these days, and it's a common theme that cuts across many initiatives that have been implemented to address COVID, as well as non-COVID related health issues. you'll see Infoway doubling down on our virtual care efforts over the coming months, particularly in the areas of mental health and primary care, where the need is great and the impact is significant. I suspect the reasons for this are obvious to you, and I'm sure I don't have to educate this audience about the benefits of virtual care. We've already seen the difference it's making in terms of improving access to care in these uncertain times. Indeed, a recent survey that Environics conducted on our behalf found that 94% of Canadians agreed technology is important during an event like a pandemic because it gives them access to healthcare when they need it. In the same survey, 86% of Canadians said that COVID-19 pandemic has shown them that virtual care tools can be important alternatives to seeing doctors in person. In addition to quantifying Canadians' attitudes and perceptions of virtual care, our survey data is also reminding us that it's not just about the technology. 42% of Canadians feel they don't understand their own health information well. Nearly 6 in 10 don't feel that they know enough about digital health apps and services, and 43% aren't comfortable enough with apps and technology in general. This data underscore the need for us to ensure that along with the technology, Canadians have the digital health literacy skills they need to have to get the optimal care experience. And we've also heard similar anecdotes from clinicians. Often they're not comfortable with technology, or they haven't been trained thoroughly enough to use it proficiently, and they're often thrust into the tech expert role as they try to help their patients navigate it. This shows that we must and we will incorporate change management, education, and other key enablers into our work. Before I conclude my remarks, I want to do two things. First, I want to give a shout out to all of you who are out there working hard to ensure Canadians are safe. The work that we do in health informatics has never been more important and has never been more visible. One of the bright spots in the pandemic is that it's probably helped us progress by at least a decade in terms of access to virtual care and digital health services. A lot of effort has gone into getting us here, and a lot more effort is required to ensure that we can maintain this momentum going forward. But I've got no doubt that it's our turn to shine and to showcase what we can do here. Finally, I'd also like to acknowledge and thank our patient partners. COVID has been an especially anxious time for those who require medical care or who have supported a loved one in the system. We've all heard tragic stories about the cancellation of needed surgeries and services, or the inability of people to visit family members in care. As we move towards our new normal, we must do a better job listening to patients, families, and caregivers. I referred to unprecedented levels of collaboration a couple of times this morning. Going forward, this phase must include collaboration with those whom we serve, patients. Their voices, their expertise, and their experiences are critical to our success. That's why I'm especially pleased to announce today Infoway's Patient, Family, Caregiver Recognition and Inclusion Statement. This statement, which was developed with our patient partners, acknowledges the critical role of patients, families, and caregivers. It also underscores our commitment to collaborate with them as we work towards improving the health system. Going forward, this statement is going to be read at relevant internal and external meetings to ground us in our discussions and remind us of our responsibilities towards patients, their families, and caregivers. The statement reads, "We recognize the unwavering commitment and essential impact patients, families, and caregivers have, and always will have, on the Canadian healthcare system. Canada Health Infoway pledges to continuously listen to the perspectives and learn from the lived experiences of patients, families, and caregivers to ensure respectful collaboration in the work we do and influence. We look forward to building true partnerships and acknowledging shared successes." So with that, I'm going to conclude my remarks. I'm going to wish you a very successful conference. I hope you enjoy the excellent program we put together for you today. And if you've not done already, please go on and register for the next two partnership full sessions. First one being, or the next one in October on the 13th, and then on November the 17th. So that concludes my remarks, and I think we have a little bit of time if there's any questions. So thank you very much.
Thank you, Michael, for that wonderful update, and especially for that really powerful inclusion statement. I think that's a wonderful step, and I hope to see other organizations emulate it as well. We do have time for one quick question from the audience. As I mentioned before, though, that we'll be able to respond to a couple more in the wrap-up communications. So one that came in, somebody is wondering, what are the main hindrances for the average Canadian to obtain their personal health data from medical practitioners and hospitals through a mobile app?
Well, that's a big question, and it requires quite a complex answer. But I think one of the main areas is getting the interoperability. And that's something that we've been focusing on and will be a kind of renewed focus over the coming months. Making sure that we can connect the institutional data with the information that you may have from your primary care physician and releasing that for individuals, and doing it in a way that is private and secure, making sure that the right information goes to the right person. It's not an easy task, but I think it's one where we're getting there. We've seen a number of patient portal initiatives that were kicked off across the country, and I think the momentum is there to continue to improve those activities. And this is an effort really that involves not just Infoway, but the private sector, the caregivers, it involves the primary care physicians, the ministries of health, and everybody in a collective effort to get this improved. And I think it's something that's faced by really every country, but it's something that we really do need to solve so that we have got eloquent solutions going forward.
Yeah, it's so interesting to hear that. I went through the process of pulling my own medical records, and they sent me a whole box full of Xerox copies that I had to then wade through that were entirely incomplete as well, because not all of the sites, the treatment sites, were connected. So it's so heartening to see this progress. I think we have a couple of minutes. I maybe fit in one more brief question. How can startups reach out to and work with Canada Health Infoway and Prescribe IT?
I think the way that startups can do that is, first of all, they can welcome to contact us. So, you know, all our addresses and our website has got the contact details on there. We are also looking at what activities we can do to help convene and kind of accelerate adoption of innovative new technologies. We have a kind of commercial partnership forum. It was called the Access Alliance. And I think the partnership meeting is a great place to do this. So we have strong support from industry. And, you know, personally, you know, I really am wanting to be an advocate of Canadian industries and innovators wanting to get into this space. So, you know, we can really try and help you as much as we can, provide contacts with the right people in the provinces, and we also have some expertise around procurement and other areas that we can definitely assist.
Wonderful. Michael Green is the President and CEO of Canada Health Infoway. Michael, thank you so much.
Thanks very much.
To really be able to hear others talking about the social determinants of health in such informed ways. And all of your speakers today talked about the many diverse social determinants of health and mental health. So, you know, I think it's important in times like these especially that we focus on the social and emotional connections that we can build, however we can build them, even while we're physically distancing. And if you've missed any of those other presentations today, or if some of your colleagues are asking about them, the recording for this event will be available by the end of the week. Please watch for the wrap-up email in your inbox as well. Thanks again to the Access 2022 Alliance founding sponsors, and a special thank you to everyone who joined me today for your participation. We'll see you back here again on October 13th. I've been Mark Henick, and it's been a pleasure spending time with you today. Spending time with you today.